If we talk about culture, I think cultural humility isn't an add on to nutrition care. It's actually central to effective care.
Welcome back to the Nutrition Newsroom. This is a special segment of the Exam Room Nutrition Podcast where we break down trending nutrition headlines with a variety of expert guests. And today I am really excited to be having this roundtable chat with 4 other dietitians from a variety of different cultures. And we're going to be talking about how culture impacts food and the recommendations that we make for our patients. If you're new here, welcome. I'm the host of the Exam Room Nutrition Podcast, Colleen Sloan. I'm a registered dietitian and a PA, and this podcast is your guide to giving better nutrition advice. So we're going to be unpacking all things culture and how it relates to your nutrition recommendations. So my first question for this amazing group of dietitians, introduce yourself to the audience and tell us what culture you identify with. And then what's one common misconception or maybe like a piece of misinformation that people have about foods from your culture?
Hi, everyone. I'm Vandana Sheth, and I identify as an Indian American. I was born and raised in India, but I've lived longer in the United States, and I really see my life from both perspectives, both lenses. A common misconception when it comes to Indian food is that it's really heavy, it's very oily, it's very carb heavy. And it's just like anything else. It's skewed. Traditional Indian food can have so many wonderful nutrients and ingredients in it. And the second sort of misconception I want to touch on is that Indian culture is very monolithic, whereas Indian culture is very diverse. If you talk to someone from the north or south, the food choices, the way they prepare foods are very different.
I'm Marely Gutierrez, and I'm a kidney dietitian, and I identify as a Mexican American. I was born in the U.S. However, my whole life I grew up in a border town called Huaslico. It's literally 10 minutes from Mexico, so it kind of felt like I had the best of both worlds. And I feel a big misconception for Mexican food is that, very similar to what you said, it's very fatty, very carb heavy. It's unhealthy, and that it's the reason for why Hispanics or Latinos have high rates of diabetes or high rates of kidney failure, which I know we'll get into this. It's really not as much about the food as other social determinants of health. And especially being a kidney dietitian, there's all these myths surrounding the potassium in fruits and vegetables and providers wanting to cut out fruits and vegetables, which again is not what the current science says. So big things for me to bust myths on.
It's really good to have you back on the podcast, Areli. You are actually my guest for episode 76, and it feels like an eternity ago, but I'm just so honored to have you come back because that episode we actually titled, Are Your Assumptions Hurting Your Patients? Rethinking Ethnic Food. And we really unpacked the misunderstanding about Mexican food and that, traditional Mexican food can be really, really nutritious. So I'm really excited to hear your insights again. And if after this episode, you guys want to go check out more about Areli and how we can have conversations about ethnic food, I'll link down to episode 76 in the show notes.
Hi, I'm Jerianne Kusipag. So I'm born and raised in Manila, Philippines. I identify as Filipino. And one common misconception that I often hear is that Filipinos eat too much rice. And this automatically makes our food unhealthy. Rice is a staple for us. And in reality, it's usually eaten with vegetables, legumes, and seafood. And it's also shaped by affordability and food access and not just personal choice.
Hi, my name is Patty, and I'm from Nicaragua, born in Nicaragua, but I identify as Nicaraguan American. I've been living in the United States all my life, so I'm definitely a mutt. As far as the misconception, I would like to think it would be specific to Nicaraguan food is that it's all fried foods. We do fry foods, but we do also treat foods other ways that are healthier, and also that the misconception that all Latin foods are fall under the same umbrella. I would think that there's just so much variety within the Latin cultures that we all do something a little bit different.
I love this group of beautiful women. This is going to be so fun to have this chat. So, I'm actually American. I was born and raised in South Florida, but South Florida is really unique because it's really a melting pot, especially when it comes to Latin food. So, I've gotten a lot of exposures to a variety of different cultural foods there. I'd love to start this conversation with a definition of cultural diversity. And so, I would love to hear when you hear that phrase, what does that mean to you?
So, to me, cultural diversity in nutrition means recognizing that food is not just macronutrients, it's identity, it's memory, it's belonging. And when it comes to clinical care, it means that we don't assume a default plate. We begin by understanding what already exists in our patient and our clients' lives and their eating patterns, and we can build from there. That approach improves long term sustainability and real world implementation. And as practitioners, that's truly what we want. We want people to feel heard. And so that's what I think of when I think of cultural diversity.
Having had I have a podcast specifically on like cultural foods. I've been getting so many different insights from my guests. And the number one thing that I've learned is that we're not aware of our own biases, right? Because you don't know what you don't know. You're only exposed to so much. So culture diversity for me is starting from scratch, starting from zero. Like, yes, it's great to be familiar with certain food patterns, certain cultural foods, but there's so much to take into consideration, like assimilation, religion. Did they marry into someone who's of a different culture? There's so many things that can impact how someone eats. So even if you see a patient and they look like they're Latino or Filipino, anything, you have to understand they might not necessarily eat that way. So you always start from zero.
Yeah, I definitely have to agree with all the lovely ladies here. Diversity, to me, what it means is being open to what your patient is going to provide. Like what Adeli said was just definitely don't have your biases. Like we can't assume that they're going to be eating yogurt and oats and all this stuff that maybe we are very much exposed to, but to them they're not exposed to it, so it's not diverse and it's not going to be appropriate for them. So I think openness as a dietitian is definitely important for the diverse.
Patty, that's a really good point. Number one, we have to acknowledge that we have bias, but also to kind of combat that is just by being curious, instead of assuming, quote, Mexican food is unhealthy because it's fried or whatever the misunderstanding is, you can just ask, wow, that sounds like a really interesting dish. Can you tell me how that's prepared? Or what ingredients do you use to make that? And I think that curiosity is a great way to combat bias. My next question kind of piggybacks off what we're talking about, but I would love to find out from, your perspective if you have ever felt like mainstream nutrition messaging didn't reflect the way your family or your community eats.
I think, especially because Mexico is so close to the US, I feel like a lot of people think they know what Mexican food is. There's a lot of Tex Mex restaurants out there. And if you've only been exposed to like Tex Mex restaurants, you might have a very different idea of what traditional Mexican food looks like. And even within like Tex Mex itself, it's like a spectrum. Like you have everything from something very Americanized like Taco Bell to something that maybe is like um, Mexican food that was created in Texas. So depending on what people have been exposed to, they have a different idea of what like traditional Mexican food is. And even within traditional Mexican food, like was mentioned earlier, whether you lived in the South or whether you lived in northern Mexico, whether you live on the coast, it can be completely different.
I just wanted to add similarly, when I think of traditional or typical American nutrition messaging when I came here over 3 decades ago, I remember looking at the messaging. It was all cereal and sandwiches and salads. And many of my Indian American clients don't eat those foods at home. And so recognizing that, yes, we can swap some of those, but for a patient or client to have to make that mental translation every time they see nutrition messaging, it becomes tricky for long-term sustainability of messages. So that's where we come in as healthcare providers to translate, to bridge that gap between what they see on a message to how it can really apply in their life.
Going off with what Vandana and Aurelie has already said, mainstream nutrition messaging mainly is Eurocentric or Western. So it pertains like sandwiches and salads are more healthy. And in reality, that's not how our immigrants and communities of color eat. So that kind of invisibility has consequences. It can make people feel like their cultural foods doesn't count or even not healthy.
So I'm even thinking about the previous visual that we had, which was the My Plate, which I loved for its simplicity and is a great, fast tool to use. But even thinking about that from the American lens, it does make sense. That is how a lot of our meals are proportioned. But if you have a bowl meal, which a lot of cultures consume bowl meals, it's really difficult to see where those different foods fit. And so I would love to move into a conversation about the dietary guidelines, not just the visual change because we've kind of eliminated the My Plate and now it is a pyramid, but there really is no reflection of cultural foods on the pictorial of that upside down pyramid. But also, I didn't see any mention of cultural inclusivity in the guidelines itself. So please correct me if I'm wrong. But I would love to hear your reaction when you read the guidelines and with the explicit removal of the reference to cultural foods.
I was concerned when I looked at the new dietary guidelines because we have strong evidence that shows that culturally tailored interventions, nutrition interventions, can positively improve diabetes, cardiometabolic health in the long term. And so removing explicit language that risks signaling that culture is secondary and instead of it being foundational to how people live their lives. So I think guidelines do influence reimbursement, education, and policy, and our language really shapes our practice.
I'll chime in. For one little thing that I noticed was just the inversion of the pyramid. How now we have the grains as teeny tiny bit of representation, just a fraction of our meals, and rice is such a huge component in international foods. I think it's been so stigmatized as something that's just horrible to have. You can't have it. Shame on you if you're going to have like so much rice. Yes, the quantity is important, but you have it with beans, which rice and beans is so it's ubiquitous, really, in so many cultures that to put grains as such a tiny, minuscule part of your meal, it doesn't speak to diversity at all.
And I remember having a little bit of an issue with the My Plate because again, like if you're using a bowl or you're having a curry, you're having picadillo, that's not what our food looks like. So when I would translate that to my patients, I would be like, okay, let's kind of think of it in terms of percentages, right? You want like the majority of your meal to be vegetables. If you are doing, for example, a picadillo, how can we add in more vegetables so it takes up more space? And so there were so many people that were working on that, right? Creating infographics. Like, I don't know if you follow Dr. Kari, I forget her full name, but she was in charge of creating infographics that were culturally inclusive. And she was so proud. I went to go see her speak. She was so proud that they had come up with all these different My Plate infographics featuring different cultural foods that she wanted to share with us. And that day that we tried to log on to see it, they were gone. So imagine all that work that was put into cultural inclusion and then just wiped away.
I was honestly disappointed. I felt that years of progress we're taking a step back from it in recognizing culture as central to our health. And I think also it sends a message to the public that culture is optional and it doesn't, when it's actually foundational to effective health promotion and for chronic diseases as well. And especially, we are in a multicultural nation. We are not a monolith here. So, yeah, I felt really disappointed with that.
Yeah, and I think this is where our previous guidelines did a much better job, although space for improvement, and it would have been so cool to see some different cultural my plates reflected. But even, guideline 2 says customize and enjoy food and beverage choices to reflect personal preferences, cultural traditions, and budgetary considerations. And they had, several sections that talked about how we can, include different cultural foods to reflect their specific culture and traditions to help communities across the country eat and enjoy a healthy dietary pattern. And I think, it brings in the fact that food is not just about its nutrients, it's about culture, community, pleasure, satisfaction, enjoyment. And a lot of that has to do with how we gather around the table and how we can pass down cultural foods and part of our rituals to our younger members of family. So I think that was a huge miss in the current dietary guidelines. What other concerns do you guys have about culture being pretty much completely absent from national nutrition guidelines?
I think for me, culture being absent from our guidelines, it just widens the inequities, especially for immigrant, indigenous, and minority groups whose eating patterns are already misunderstood. Going back to our previous conversation about the misconceptions, and they are already underrepresented in the data. So I think culture being absent from the guidelines is that it just sends a message that culture is not relevant at all.
I just wanted to add to what Jerry Ann said that, when we risk unintentionally reinforcing one dietary pattern as the benchmark, we know evidence based frameworks like DASH and Mediterranean eating patterns are valuable, but they are templates, they're not guidelines. And so if cultural flexibility isn't emphasized, our patients may perceive their food as barriers rather than assets. And that's really where we can step up and make that difference.
Yes, and it's something that is very heartbreaking because I feel like those myths about cultural foods being unhealthy are so pervasive. They're so insidious that I've heard it from my own people. I've heard it from other Mexicans, Mexican Americans saying, like, I would lose weight, but I don't want to give up my cultural foods. I would control this. However, how could I ever give up? So they've already made that connection that like our food is the problem.
I think it's similar messaging to where people think that if they're in a larger body size, that something is wrong with their body, right? It's messaging that we can tell them, oh, your food is unhealthy. And that just comes from a lack of knowledge, a lack of understanding about that food. So with cultural recommendations and inclusivity lacking in the guidelines, how do you think this ends up trickling down into exam rooms and the language that clinicians are using when it comes to questions about cultural foods?
I think it shows up in subtle ways. A clinician might recommend switching to whole wheat bread, but your patient may not even be eating bread. Or they're told to eliminate rice, like Jerry Ann and Patty mentioned. Rice is a big part of culture. Instead of discussing portion size or pairing with fiber, protein. And what happens is our patients often will nod, but they leave without a plan that fits their real life. So we might get short-term compliance, but really it's not a sustainable, healthy way of living for them to achieve their goals. So I'd say it can be very subtle, but as practitioners, if we can be more open, more curious, come in with questions before we naturally just give our advice, that would be a great starting point.
Bandana definitely brought up something to mind. What I noticed when I was shadowing with some patients, they were very shy. They didn't want to talk about what they were eating. And I don't think it's not to blame anybody. I just think that it's more of a psychological, like you're here with the doctor and we're just going to listen to what they're going to say, but I'm not going to say anything about myself. And the whole idea of getting these wonderful questions to get out more information about these patients and having them feel comfortable to come out and actually start to tell the provider, hey, this is what's going on and this is really what's happening with my life and this is what I'm eating. Those questions are so important so that they can feel comfortable that the dietitian and the patient works together in bringing up healthy outcomes for them.
What you might see might be subtle, and one big thing that's related to that is how much time doctors have or PAs have with their patients is you maybe have maybe 15 minutes at most. So when you're like go, 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 and you're trying to address all these different things because they're probably coming in not just for one thing, you can kind of get into the habit of making those blanket statements of being like, okay, you need to stay away from rice, stay away from, entire foods because that's just faster than having a collaborative session with a patient of being like, okay, like what kind of foods are you having? Can we pair it with this? Can we pair it with that? So providers that are listening to this, do what you can, do your best as far as being collaborative with the patient. But also this is why dietitians are such a great assist because we have that half hour or hour to get a little bit more into into the details.
So I want to linger a little bit on something that Vandana had said. And this is, I want you guys to give us some like a real look into your cultural foods and recommendations that kind of go against it. You had said to switch to whole grains. And a listener might be like, well, that's a great option. Like that is what our recommendations say to tell our patients. And so I would love some great examples of other guidelines or recommendations that sound good or appropriate or even healthful, but that might feel dismissive based on that patient's culture.
I'll go first. I think my example would be cut off white rice, where white rice is really a staple in with Filipino food and other Asian foods as well. And white rice tastes just different with our other main courses. So the brown rice doesn't just cut it. So I think that feels like very dismissive on, nutrition recommendations or nutrition advice. However, you can counter it with, portion sizes. Or personally, what I do is just mix the brown rice with the white rice so that I'm not too shocked on how it tastes with my main course or the vegetables.
I love that. And many of my clients as well in the Indian culture eat rice. And so we come up with tweaks to their traditional recipes in our sessions and figure out, how about we add some cauliflower rice? Because I specialize in diabetes and pre-diabetes. And so with blood sugar, if they're wearing a CGM, we can literally see the impact of that food. And so we customize their recommendations based on that. The second thing is many of my clients are also plant-based, vegetarian, and one of the biggest problems is when they see a practitioner who is not familiar with plant-based eating, tells them, oh, what do you eat? You just eat vegetables? And where's your protein? Because there's this big push on protein now. But there are so many delicious plant-based protein sources that these clients already eat. So we talk about chickpeas and pulses and beans and lentils and how it can give you the protein, carbs, fiber, all in one package. So figuring out those little changes can make such a difference. And as a practitioner, you don't have to know all the different cultures. It's just asking those questions first. I know time is limited. I get that. But if we can just start with one open question, maybe like, what is a typical dinner for you? That can take 1 minute, but that can open the door to you hearing what's typical for them.
One thing that I did notice was pushing quinoa on everybody, even though it's a wonderful food. But not everybody likes quinoa. Not everybody knows how to cook it. So I'm not dissing quinoa. It's wonderful. It's just to push it on somebody that's not a part of their culture.
That's a great example, Patty. And my example is going to be from the renal world. So I think something that a lot of nephrologists think is very safe to say, very appropriate to say is, if they see a high potassium, oh, you need to stop eating tomatoes, you need to stop eating potatoes, you need to stay away from oranges. Instead, you should do apples and grapes. Instead, you should do lettuce and onions. And they don't realize that the foods that are in that list of the high potassium foods are our cultural foods, right? Avocados, tomatoes, mangoes, versus the foods that you're saying might not be our cultural foods, it's not the foods that we're familiar with. So I like to step in and remind them that it doesn't matter which one you pick, they all have potassium. It's just how much. So if you want to educate a patient about lowering their potassium, which again, there's so much new evidence that shows it might not even be related to diet. But if we are going to approach diet, let's still consider these cultural foods and just educate them on portions.
I think one of my favorite things that dietitians do really well, and that is taking an addition approach rather than a restriction approach. So rather than saying you can't have white rice, what can we add in to make it a little bit more balanced? Like you said, Patty, can we add in some beans? Let's just add in an extra side of vegetables or just a side of vegetables if you're not even having any vegetables, right? So that add in approach, I think, can be much more appropriate. And that's regardless of the culture. So, my final question for you guys is to help my listeners give better counseling tips. And so, I would love to hear how you kind of balance evidence based nutrition with honoring their cultural food identity.
Vandana had like the perfect example earlier, which was to just start with an open ended question, just see even something as like, yes, a typical like 24-hour recall will take a little bit of time, but putting in that legwork early is actually going to make it easier for you to give more appropriate recommendations afterwards because then you'll see, do they eat out a lot or not? Do they like big meals? Do they like a lot of small snacks? So you're not going to waste time making recommendations that don't even apply to them, right? Or you might learn about issues like food insecurity and other things that we need to keep in mind for these recommendations.
I would say 3 tips. The first would be asking those open ended questions. And again, if you don't have time for a full 24-hour recall, a quick question about one meal. What is the biggest meal and what is typically eaten at home? That could be a starting point. The second could be, could you try to use some of those foods as you address them? Like right away, if you know the client is eating a flatbread called roti, instead of using the word whole wheat bread, if you're comfortable, use roti in your explanation because they will feel more respected, more heard. And the third, I would say, is like Colleen, you mentioned, we love adding foods. So it's about, okay, if you love white rice, let's modify portions, let's substitute, let's add something, not take it away completely from the plate. I would say those would be the key messages, 3 starting points.
I really love all the examples that everybody's saying. But to bounce off of that, definitely 24-hour food recall is a good way to get an idea of what your patient is actually consuming. And if you're not familiar with what they're eating, to research the foods. There's definitely a lot of foods that for in one culture is very is ubiquitous in one and then it's not being eaten in another. Just to ask what your patient is eating, then you can do the research, take a little bit of time if you have to come back in another session, and then you can have a little bit more information as to see whether or not those foods that they're consuming are meeting those dietary guidelines.
I also like ask if I'm going to the recommendations part, is what do they usually have in their pantry, cupboard, or fridge? At least I have an idea on their food security, on what does it look like. And from there, you could always tailor it with evidence-based nutrition. You can adjust with the macros in fiber, in sodium as well.
I think Colleen had mentioned, how do you balance evidence-based nutrition with honoring identity? And I really don't think that they're competing principles. We can use evidence-based information if we know for my clients, higher fiber intake can help with glycemic control. Then let's figure out foods within their culture that they can apply, they can use day to day to enhance the fiber intake. And that is taking that evidence based information and applying it to the nutrition, to honoring their identity.
Absolutely. That was my first thought was like they're not mutually exclusive. And what I really love is that there's people out there doing the research about how our traditional foods are impacting different comorbidities. So I ran into a researcher at the last kidney conference that I went to, and she was doing research on the Las Milpas diet, right, which is something that's Hispanic, Latin-based diet, and it's very heavy in like beans, legumes, rice, whole grains, corn, and how that impacts diabetes or how does that impact chronic kidney disease. So I really like that. Again, there's more research being done, and I hope it continues to learn more about how our foods are actually healthy.
Okay, so what do you think? What are some recommendations that maybe medical schools or even colleges can do to help educate up and coming clinicians so that they can be more culturally inclusive once they become practitioners?
Okay, so I would say if there was one thing I would change about medical training, it would be that if we could integrate applied cultural case discussions into clinical education, embedded into metabolic management scenarios rather than having just one cultural diversity lecture. It needs to be part of their overall curriculum.
And even to have like the medical students start practicing that with, in class, how to have that counseling session and practice those questions, is a good start. Yeah.
I was also like leaning towards that suggestion, like a case-based, counseling sessions, but very particularly on culture, for example, Caribbean, South Asian, West African, South American, Latino culture, so that at least they get familiarized with the food, religion, and culture as well. So when the situation arises, they're more familiar on what they can say to the patient or client.
Yeah. I mean, did anybody have any kind of exposure in school about that? I was just curious. Like,
No, so that's exactly what I was going to say is that I feel that's so important in their medical training because even us as dietitians, when I was learning about nutrition, I had never heard about culture. In fact, I think when I first finished my bachelor's, I had like that messaging ingrained in myself that I was like, oh, I need to eat more broccoli. I need to eat more grilled chicken, more like Eurocentric type of dietary pattern because that's what we were taught was healthy. Like I never saw my culture being represented. And the only time that I saw cultural foods being represented, it was in a negative way. It would be like, Mr. L has elevated glucose and he's known to eat a lot of Chinese food. So what can we educate him on? So right away they're saying, the Chinese food as if it's something negative, like as if that's the reason for that high glucose. So I feel like yes, they should be exposed to like different cultural foods in that training. So in the day-to-day life, it's not something new that they're not equipped to handle and that they don't have that bias, hopefully.
I just wanted to add one final thought. If we talk about culture, I think cultural humility isn't an add on to nutrition care. It's actually central to effective care. If we want sustainable long term cardiometabolic outcomes, positive health outcomes, we have to work with foods within someone's culture rather than just giving a prescriptive one size fits all. And dietitians are great at working on this. And it always starts with a simple question, that curiosity that someone can open up to you in your sessions, and that can positively impact their lives in the long run.
I love that. What a beautiful place to end. Thank you so much for sharing that with us. Guys, this has been such a fun conversation. I have been so blessed by learning from you and your cultures and just sharing insight into kind of a window into your culture and what it means to be culturally inclusive and respectful. So thank you so much for the gift of your time. If you guys want to connect with any of these experts, all of their contact information will be down in the show notes. But I hope that this was your reminder to stay curious and learn about a new culture today. Thanks so much for being here, and I'll see you next time.